You're very welcome to our Fireside chat. We here at Africa Healthcare Network are really proud to be able to present a variety of topics each week on Thursdays. And we are going to be continuing with our supportive care program. Each month, the first Thursday of every month, we focus on a different supportive care topic. And you may not have heard of supportive care before, but supportive care is an aspect of palliative care that we provide for patients and their families that are living with life-threatening illnesses. And we're really excited today to have the opportunity to hear from one of our colleagues here in Nairobi, Kenya. Her name is Dr. Esther Nafula. She's a highly respected palliative care specialist based at Kenyatta National Hospital, where she leads the pain and palliative care unit. Her extensive experience encompasses working in a variety of settings, including hospitals, community health centers, and also hospices. She is deeply committed to expanding palliative care and through services and education in Kenya, as well as advocating for the availability of opioids and analgesics for groups that are vulnerable, especially children and those living with disabilities. She has an educational background with a Master's of Science and a diploma in higher education in palliative care from Oxford Brookes University, and she holds a certificate in teaching and learning for higher education from the same institution, as well as a Bachelor of Medicine and a Bachelor of Surgery degree from the University of Nairobi. She's committed to professional development in furthering her profession by doing a fellowship through the Institute of Palliative Medicine in India. Her roles currently are clinical care for patients and their families, instructing healthcare providers in palliative care programming, and championing the cause of accessible and compassionate care. She's actively contributing to the International Children's Palliative Care Network as a board member of trustees and working tirelessly to improve the lives of those in need. We're so excited to have Dr. Nafula with us today, as she's extremely passionate and dedicated and has made it her passion in life to lead the palliative care community here. So I'm very excited to introduce to her. I know Dr. Nafula as a friend and colleague. I'm really excited to have her. Tonight, she will be talking about ethical issues in kidney supportive care, and she'll be sharing her thoughts. So for the next several minutes, maybe half an hour, Dr. Nafula, or 35 minutes you'll have to teach us, and then we look forward to an active discussion with those on the call. So over to you.
Thank you, Erin, for the warm introduction. I'll start sharing my screen. So this evening, we are going to be looking at ethical issues in patients with kidney disease. And we'll use some cases to discuss the issues. And to start us off, I would like us to understand what we mean by ethics when we talk about medical ethics. So ethics is a system of moral principles or rules of behavior. It's a way of life or pattern of conduct and the reason why we choose to act in a certain way. So when we are dealing with patients, we have a set of ethical principles that guide medical or nursing practice. You'll find for different professionals, like maybe legal, accounting, they do have their own ethics that guide their practice. Now, in palliative care or supportive care, the patients we deal with most of the time will have chronic kidney failure or chronic kidney disease. And this refers to gradual loss of kidney function, which often progresses to end-stage renal disease, where it becomes fatal without the patient being on dialysis or without receiving a kidney transplant, because their kidneys cannot function anymore to sustain life, and kidneys are actually one of the vital organs we have. So dialysis is considered a life-sustaining therapy. So dialysis is offered to actually save life, and in some instances, it can be used to prolong life, but sometimes it also results in a major burden for the patients, which we will look at some of these issues as we go along the discussion. It's good to highlight what some of the risk factors are for chronic kidney disease. So chronic kidney disease is common among adults over the age of 60 years, although sometimes we see it in younger individuals, but it's more common among elderly patients. And the major cause is diabetes, hypertension. We have heart disease, obesity, Also, some families have a history of chronic kidney disease. As you can see, diabetes and hypertension are top as risk factors. Then there is also previous history of acute kidney injury. The damage can result in chronic kidney disease. Then we have smoking and use of tobacco. And also on this list in Kenya, we have use of NSAIDs. A lot of patients are using painkillers to manage their pain over the counter. And chronic use of these painkillers without monitoring has actually resulted in chronic kidney failure. Now, that's just to highlight what we are looking at. So chronic kidney disease will come with a burden for our patients and families. And one of the burdens is treatment. You can see that just because there's chronic kidney disease does not mean that diabetes or hypertension or heart disease has been sorted out. So this is a patient who is likely to be on a lot of drugs and a lot of follow-up and a lot of interaction with hospitals. Now, when we come to ethical issues, chronic patients with kidney failure, there's a lot of ethical problems that arise when we are taking care of them. And sometimes the guidelines that we have for managing kidney disease do not highlight in detail these ethical challenges or dilemmas or what to do with them. So to start us off is principlism, which is basically means that it's applied ethics approach. So the 4 ethical principles that we know of beneficence, non-maleficence, respect for autonomy, and justice, it means that we apply certain ethical principles in certain situations. For example, when it comes to a principle like autonomy, we know that patients are the ones who make decisions for themselves about their treatment, and we try to respect this as much as possible. So in applying ethical principles, principlism means we follow the principles to the letter. We try to reason out based on the principles as we make a decision, especially when there's an ethical dilemma, unless, of course, there's another conflicting obligation that has greater weight. Sometimes we override this autonomy of patients depending on the benefits of the treatment, but we need to balance where there's a conflict or where we are not sure about which way to go, then what are the channels for us to be helped? So right now, a lot of hospitals have hospital ethics committees, and one of their mandates is actually to help in resolving ethical dilemmas and try to reason out so that the decision that is made is in the best interest of the patient. So we'll go through these principles shortly before we discuss now the issues that are very specific to renal patients. Beneficence and non-maleficence are 2 ethical principles that go together. Beneficence means do good and non-maleficence means do no harm. So medical interventions are offered with anticipation that they are going to benefit the patient more than to harm them. For example, the patient with end-stage renal disease, when we are suggesting that they get a kidney transplant, the idea is to help the patient to live a better life, to improve their quality of life, to restore their renal function. The intention is not that the patient is going to die in the process of getting the renal transplant or is going to get organ rejection that might be so severe and render them in ICU. So when we have a situation, we look at what is the benefit, what is the harm of the intervention, what would happen if the patient gets the intervention versus if we withhold that particular intervention. Justice is about fair treatment, that in our service provision, we should not discriminate patients based on their race, social status, gender, or any other discriminatory factors, but the services that are provided should be the same for every patient, and that when we have health services or resources, they should be distributed equally to the community. So when we look at our healthcare system here in Kenya, there's some care that is not accessible at the primary level or at specific healthcare facilities, and the patients are forced to either travel to a different town that might be very far from them to be able to access care from a higher level facility, or from a facility where there is specialized care. So when the patients come, are they getting fair treatment from us? Now, what about the patient who is in an area where, for example, dialysis is not available and the patient has end-stage renal disease? Are we really just in the care that we are providing for our patients? Now, ethical issues sometimes do not have a straightforward answer. It's about a balance. Autonomy is about the ability of the patient to decide for themselves. So every patient has a right to accept or refuse treatment as long as they are sound of mind. And we need to give them enough information about their diagnosis, the treatment plan, and the outcomes for them to make an informed decision. Now, when we look at our patients with chronic kidney disease, most of them are elderly. And it's a very common scenario to find that it's their children making decisions for them. The question to ponder about, do these decisions really reflect what the patient wants? Or are these decisions that the family is making? Because some of these decisions are not in the best interest of the patient. We find families that are telling us, do not tell the patient about their diagnosis. Some of them are opting out of treatment, maybe because of the cost or because of the inconvenience of having to come to hospital every 2 or 3 weeks. So how do we determine for renal patients whether they have the ability to make a decision, and an informed decision at that? So there's a slide ahead where we are going to look more into decision making around renal issues and just how to determine capacity, that a patient actually has capacity to decide for themselves. And even how and when should we share information with the family. Now, when we get renal patients, our ethical challenges begin at the time of diagnosis. So we've said chronic kidney disease is gradual decline over time of the renal function. Now, some patients will present when they have a burden of symptoms. They have other underlying problems that might also be very severe. So how do we decide whether to withhold or to start dialysis? When do we refer them to the nephrologist? Studies are actually showing that many patients with end-stage renal disease are referred very late to the nephrologist. You find their kidney function started declining. Maybe their creatinine levels were high, but the monitoring was not being done very well, or the interaction at the first point of contact, the healthcare provider does not have enough skills to pick out that this patient is having chronic kidney disease. What are the parameters that we need to look for so that we are able to refer them early enough before they get to end-stage renal disease? Are we just maintaining patients on their antihypertensives, their diabetic regimens, without consulting the experts in managing these illnesses? Are we prescribing painkillers generously without even knowing the baseline kidney and liver functions of our patients, and they end up with renal failure? They end up needing transplant, and even at the point where we are referring them, sometimes it is too late, that the nephrologist has to decide whether this dialysis is going to actually improve the quality of life of the patient, or it's just going to add to their burden of symptoms because now the prognosis is very bad. So I do hope that part of the series we are doing is actually to help our healthcare providers to have skills to pick out acute and chronic kidney failure and to know when to refer and how to refer. Now, prognosis is very hard to determine, especially in patients with end-stage renal disease. And we've handled many cases where dialysis has been continued and it's not offering any benefit, and sometimes it is withheld when it would offer benefit. Now, as I mentioned, ethical issues are very hard to decide on. Now, I'll give a case scenario and feel free to type in the chat whether you think that the patient and the family made the right decision in this scenario or not. So we have a patient with end-stage renal disease. She was 85 years old, has been on dialysis for 10 years. She also had interstitial lung disease and had a tracheostomy and was on home care. For these 10 years, she has been going for dialysis twice a week, biweekly dialysis. So the patient develops confusion and she goes into hospital because the family feels she's confused more than normal, and her creatinine levels are checked and they're at 1,000, and the patient has missed her dialysis for 2 weeks, and the nephrologist suggests that we should do some urgent dialysis for her despite the hypotension. But the family decides that, okay, our mother has been sick for the last 10 years, and this is not quality of life, so we are taking her back home. We are withholding the dialysis. We are ready. If she's in end of life, we are ready. We will not do the dialysis. So the nephrologist tells them this dialysis will save her life. It will prolong her life. And the children feel this is prolonging suffering. So at the point palliative care was called in is now the family wants to take the patient home. Remember, this is a patient with creatinine of 1,000. She's confused. She cannot make a decision. And they signed a discharge against medical advice and took their mother home, and she died within a week of the discharge. Do you think that the family made the right decision? You feel free to type in the chat. I'll give you just a few seconds. I think in the Q&A section or in the chat. Did the family make the correct decision to take their patient home against medical advice? No. So I have answers of no trickling in. There's a yes. There are a few who think yes, and there are a few who think no. I do not have the correct answer because when we look at the prognosis of the patient was 85 with interstitial lung disease, and she also had chronic kidney disease, had been on dialysis for 10 years with no hope of recovery. So the question now is, yeah, the family felt this is just too much and we need to give up. So with ethical issues, it's about justifying your decision. So I think the nephrologist was right to want to give dialysis because the patient was having symptoms. She was anuric, she was confused, and the family felt now we've had enough. If we are at the end, let us take her home. So sometimes it's very difficult when you're sitting on the side of the doctor or the nurse trying to advise the family. And the question that lingers in my mind about that case is whether we could have done more to help the patient, because this was not the patient's decision, it was the family's decision. So dialysis is prescribed with a thought of saving the patient's life, and there's consideration about the side effects and the burden of dialysis. So patients do get the mahuka, and sometimes they also get the fistulas for dialysis, and they have to live with these things, which sometimes cause a lot of pain, and it's a lot of discomfort every time they come for dialysis. And there's times where we actually need to look at the benefits of this dialysis. Are we providing just care without curing the patient? And is this care actually warranted? Now, again, we look at the quality of life. What is the side effects and treatment burden versus the benefits of the dialysis to the patient? Remember, dialysis itself takes a couple of hours in a day. It is done for many patients with end-stage renal disease. It is 2 to 3 times in a week. So that means the caregiver of the patient is not going to be productive. They need to take an off from work every other time, maybe 2, 3 times in a week. And we've had scenarios where the patient has to bring themselves to dialysis because the caregivers are not able to come. It also comes at a cost. So when we are considering the issues of quality of life, it's important to look just not at the benefits of the dialysis, but how is it affecting the patient psychologically? How is it affecting them financially? How is it affecting their family? And are there ways that we can still provide this care and ensure that the patient has quality of life? For example, is it possible if the patient has working caregivers, can they come for the dialysis over the weekend? There are options of doing dialysis at home that some countries and some institutions are providing. Is that a possibility for the patient? Then now we go to information. Remember, dialysis is an expensive procedure. So there's financial gain for the institution and the treating physician. I asked the question of when dialysis becomes medical futility. Now, sometimes we prescribe treatment not because it's going to benefit the patient, but because I'm going to earn a consultation fee every time the patient comes for dialysis, or the institution is going to gain by having higher numbers coming into our renal departments. So there's a case here of a 58-year-old physician who is a pioneer of peritoneal dialysis for chronic renal failure. So he consistently coerces his patients to maintain peritoneal dialysis rather than hemodialysis, even when the patients do not need the peritoneal dialysis. By contrast, another nephrologist at the same facility who is an expert in hemodialysis does not consider the peritoneal dialysis as a choice to his patients who are uremic. So sometimes it depends on, the treatment will depend on the facility, and this is where the principle of justice comes in. Are we really being just to our patients when we prescribe treatment just because we have some vested interest in that treatment? Maybe I'm doing a study of how patients respond to peritoneal dialysis versus hemodialysis. So I prescribe them the earlier treatment, not because the patient needs it, but because I need some information. And we've seen this happen a lot in our institutions, that patients are getting treatment that would be considered futile or would be considered not beneficial to them, but we do it because there is financial gain. Now, when it comes to information, how much information do we actually share with our patients? Do we sit them down to explain to them, this is your diagnosis, this is the treatment plan, this is the expected prognosis? The 85-year-old patient had been on dialysis for 10 years. So at 75 years, he started dialysis. It's very important for us to give information to patients so that when they have capacity, they can actually make decisions for themselves, which is advanced care planning. So the patient can tell us, for example, if this patient had expressed her wishes and said that at some point, if the renal disease, end-stage renal disease, and there's no hope for recovery, I do not want to continue with dialysis. So that would have been respecting her autonomy. But now, in situations where we are not sharing information with the patient, we are giving them even false hope and telling them they'll get better, so go for dialysis, but we're not sharing with them that this dialysis is going to be lifelong, or for as long as you will be able to get a donor for your kidneys. Sometimes the information is being shared with the family members and not the patient. So the patient has no idea. They might know, yes, I'm going for dialysis, but they might have no idea about what the treatment plan is, what their prognosis is, what the future holds for them. So they're really not able to make an informed decision, and they're not able to be part of their treatment. We are now advocating for patient-centered and family-centered care, and it's important for us to share information with the patient first, as long as the patient is sound of mind, and then we share this information with the family and empower them to know how to support their patient. And the only way we can do that is by actually discussing with them about their underlying problem, the expected plan, and the outcomes. So decision-making and consent, patients give informed consent when they have information, and this information should be shared with them in a way that they can understand. So you do not come and tell the patient that you're going for peritoneal dialysis or you're going for renal replacement therapy, hemodialysis. Those terms, to a lay person, they do not understand what that means. So it should be explained to the patient in a simple way for them to understand. And in decision-making, we should consider what the preferences of the patient are. So preferences here could include the place of care. Do they want to be at home? Do they want to be in hospital? Do they actually want to come to your facility for dialysis and for nephrology review, or do they prefer to go to a facility closer to home? And we have to assess their cognitive abilities first, and then give also our professional recommendations for treatment. And the principle of autonomy actually dictates that we respect the decision of the patient, even if that decision does not make sense to us. As long as we've given them enough information and enough time to decide, we need to respect that. When it comes to assessing cognitive abilities, it is a bit tricky, especially when the renal function is not good. So there has always been ethical issues being brought to the ethical committee, where a patient with high ureas or high creatinine has signed consent for a procedure or has declined treatment. The psychiatry team tells us the patient is sound of mind. The nephrologists feel, no, with this kind of uremia, the patient will be confused. They cannot make a sound decision. So there's a thin line between determining whether your patient is sound of mind and able to make decisions. And because this is a chronic illness, the windows where the patient is sound of mind are the ones that we use to get decisions about their treatment. Now, some of the special concerns that we have when making decisions include when the patient has insufficient decision-making capacity. So the patient who is confused, the patient who has other underlying issues that are reducing their cognition, like maybe they have dementia and they're not able to decide for themselves, are we able to get a medical proxy? In Kenya, we do have a problem because the medical proxy is automatically assumed to be the documented next of kin. But we know healthcare is very expensive in this country. So a lot of patients, when they come to hospital, the next of kin is the person paying the bill. It might not actually be the person that has the best interest of the patient at heart. And some of the decisions they make are based on how much is this treatment going to cost. Yes, what is the downside of keeping the patient here for long? So it is important to get to know the family dynamics and to get to know who is the medical proxy for the patient. When the patient still has capacity, they can tell us, this is the person I trust to make medical decisions for me. What about when there's a poor prognosis, like our 85-year-old with interstitial lung disease, chronic kidney failure, now has become anuric? We are sometimes unable to actually give a good prognosis, or rather to prognosticate well. So it is very tricky. Sometimes you will withhold the dialysis and then the patient dies of now acute kidney failure. And it is very difficult to tell the prognosis of this patient. So there are things that we see and we know the patient is in end of life. For example, when we're dealing with these patients in palliative care, there are some signs or prognostic indicators that we can see. For example, if their overall performance status, that means they're not able to get out of bed, they're not able to do things for themselves, like activities of daily living. So sometimes these are things that could indicate a poor prognosis, but it really is a delicate balance. Then we have non-compliant patients, the ones that treatment is prescribed for them, but they just choose not to come. They'll always come back with complications, or they go and get lost to follow up. We have pregnant mothers that might need or might have chronic kidney disease and might need interventions that will put their babies at risk. And we have to consider that. Do we consider the health of the mother first or the health of the fetus? We mentioned some of the concerns about geriatric patients, including decision-making, and whether it's just their families that should decide for them, or we give them a chance to make decisions for themselves that reflect what their interests are. And sometimes the older patients will tell you, let my children decide because they're the ones paying the bills, or I'm at their mercy. But is that really just? Is that really fair for the patient? I would like now to, for the next about 10 minutes, to look at issues concerning renal transplant. And this is the tail end of the presentation. So in Kenya, the renal transplants are done once a patient has a donor, and we use living donors where we harvest the organs from a donor and implant into the recipient. So there's a lot of gray areas with using living donors because most of the time, the people who are donating the kidneys are relatives to the person who is sick. We've even mentioned that one of the risk factors for chronic kidney disease is family history of chronic kidney disease. So we are now starting to see patients who donated kidneys to their relatives. Then the remaining one kidney becomes affected with chronic kidney disease or a similar illness to the person who was receiving the kidney. So that is one of the challenges we have. Then with the recipient, and now there's issues of resources. And those two, I'm going to look at them as we look at the next slides, but I would like to talk a little bit about procurement of organs and tissues. So the law in Kenya prohibits selling of organs and tissues, which include blood and kidneys. But we do know, we've seen very many cases where donors are donating their kidneys because they have agreed with the recipient that you're going to pay me a certain sum of money for me to give you my kidney. So we've had scenarios very recently where a donor got to theater and asked where is his payment. He has not seen any money in his account. So he declined while on the theater table to give out his kidney because he has not been paid. Yet our law states that we should not sell organs. Informed consent, will come back to it. Now, we have donors. We've mentioned they're living donors and they are related to the recipient. It's very common that when we are trying to get informed consent from the donor, that we get scenarios where we are realizing that this donor is not a voluntary donor. They're supposed to donate their organs voluntarily. They're supposed to donate their kidneys voluntarily. We've had scenarios where someone tells you, my father is sick and he has promised that he'll only allocate me the land that I should inherit if I give him my kidney. This is my brother. My parents died and my brother is the one who has raised me. And I feel that if I do not give him my kidney, I will be failing him because he has given up my life for me. He has given up his life for me to be able to get a good education, to get a good job. So the issue of coercion is very common, and it's actually a big problem right now in Kenya because the donors, they're not willing donors. They're being coerced, they're not doing it voluntarily. And yet we know that the risk of donating a kidney, the risks are higher for the donor than for the recipient. The recipient already has chronic kidney disease, many other problems. And a donor, we want someone who is healthy with healthy kidneys because we are going to harvest one and leave him or her with one kidney. And yet, they're the ones who are likely to even die following the transplant procedures. They're the ones who are at a higher risk than the recipient. So how do we get informed consent from them? Do we explain to them the extent of the risk that they're putting themselves into to be able to donate the kidney? It's very common that when we do this, they withdraw. That when we inform them that these are the risks of this surgery, these are the risks to your life. Again, if you're from the same family, you could get this kidney disease. Many of them withdraw and refuse to donate. So we are hoping that we will soon start to have donors, because we are not allowed to get organs from patients who are brain dead. But that's where we need to move to, because currently our pool of donors is declining. And the donors that are there want some form of reward for donating their kidneys, be it in cash or kind. When we come to the recipient, sometimes we have centers that have organs. They have storage, or they have many donors, or they are able to get organs from dying patients. So the ones who are brain dead, or the ones with a poor prognosis but good organs. And the question is usually, this individual who is going to receive the kidney, who should be prioritized? Do we give the kidney to the patient who came first? Do we give it to the one who has preserved their organs well, the one who did not smoke or drink and is only suffering from hypertension or diabetes? Or do we consider them equally? So is there a way for the scarce organs to be given justly to the recipients? Then our recipients also, is there a way for them to actually ensure that their donor is volunteering? Because the recipients are the ones now in Kenya who are sort of coercing or forcing the donors to donate their kidneys. We have children who will come and tell you, my parent has told me if I do not donate my kidney for them, they'll disinherit me, they will kick me out of the house. So I am just here because I want to save my parent, but I do not want to give up my kidney. What happens to their relationship after that? especially sometimes if we get complications during these procedures. And for the recipient also, we need to ensure that they give us informed consent, that they understand the risks of the organ transplantation. And some of the risks actually include rejection. It includes severe reactions of the rejection that could lead to death. Also, does the recipient understand that getting a new kidney is not going to cure the underlying problem that caused the kidney failure? So for example, we give them one kidney, the hypertension, diabetes is still there. So they still need to continue with follow-up, and there will be now extra anti-failure regimen. Thank you for your attention. We could now go to the chat and Q&A. Thank you. Back to you, Erin.
Thanks, Dr. Esther. Yeah, you've covered so much content, and I know there's already some questions coming in, but yeah, Dr. Yuri, do you have any initial thoughts on Dr. Esther's conversation today?
Thank you, Erin. It was quite enlightening. Thank you, Esther. Actually, just a disclaimer. Esther is a friend. I've known her for so many years. I think
nice.
when we started just after med school, I think we were actually in the journey together. So I know her from way back.
Yes.
And it's I'm really proud today just to listen in on this presentation. And actually, she has touched on so many points, very important, especially on a lot of the cases that we encounter day to day, especially the ethical dilemmas that we see. I think one that I've seen that has been recurring quite often is we get ICU patients who have already signed DNR. Some of them, I think even in the wards, we also get DNR patients, but they still come in for dialysis. So I usually look at it and I wonder, if a patient has already signed DNR and you find it's a patient with a terminal illness, basically at end of life care, but we are still prolonging the inevitable. But yes, these things occur from time to time. And I think also the cases that have been shared, very, very live cases that we also see where you have a dilemma where we have elderly patients, because I know in some of our centers, we even dialyze patients who are 90 years old. Of course, at that age, you know, creatinine is always high. Kidneys are not at their best because of age, but again, they're being pushed to dialyze. As much as, yes, we say for dialysis units, some cases, as much as, yes, there's also the bottom line where you have numbers, but again, there's also the part of providing quality care and also safe care and a care that is also ethical to patients. So yes, I think it's again an eye-opener to us and also a challenge for us to also consider having ethical committees to discuss some of these cases at depth. And then we also get a family conference and decide together as a team. Because like the case that was presented earlier where relatives, or I think whether it was the children that had declined dialysis, the question is, was this the best for the patient? Did we get the patient's voice in this, in terms of saying, I don't want to go ahead? Or was it just a case of caretaker fatigue? Or what sometimes we see with most kids, like in Kenya, where they're saying, if our dad dies early, we can inherit our piece of land. So they just push them to the grave. So you never know. It's kind of a balance. But yes, thank you. I call her Dr. Esther. We always refer to each other with our first names. But it's hard for me to call her Dr. Nafula, but she knows. But thank you. Very good presentation, very enlightening, and looking forward to have many, many more in future. Appreciate it. Thank you.
Nice. Thank you, Dr. Yuri.
Yeah.
Nice that you guys can have a reunion over Zoom. Dr. Nafula, you've touched on a lot of topics today, and there's a few questions in the chat, and I'd love to go to them. So there was one at the beginning of your discussion talking about beneficence and maleficence. So related to transplant. So I know you ended your discussion related to transplants and donors. So how do we, I guess, decide to transplant someone with end-stage renal who has potentially other issues, so other autoimmune disease, And then specifically, is there a risk of, I guess, them not being able to receive transplant? So a very specific question.
Yeah, I think for autoimmune diseases with end-stage renal disease, as Dr. Yuri has said, most of the time, these are patients who might actually be with a poor prognosis. So the question would be, if we give them a new kidney, the autoimmune disease is likely to still attack that new kidney. So are we going to add to their burden of disease, or are we going to make it better? So the way I would look at that scenario is to look at what is the prognosis. So yes, you have an autoimmune disease, but what is your likely prognosis? And the question to ask is, would you be surprised if your patient was dead in the next 1 year or 6 months? And if the answer is yes, then we can proceed to consider dialysis. But if you would not be surprised, then it means the prognosis of the patient is poor. So the focus should be on improving their quality of life rather than just giving interventions. Now, patients who are in end of life, dialysis is actually considered as a life-sustaining or life-prolonging therapy. So dialysis is thought to actually just add days of suffering to them, especially when now a patient is in the terminal phase of their illness, or a patient is actually in end of life and actively dying. Do we really need to give the dialysis? And in practice, having these conversations with the patient beforehand helps. And if it's not possible, because sometimes we just meet the patient at the end of life, we meet them in an ICU, can we help the family to understand that the dialysis is actually futile, a futile intervention? It's not going to change the overall picture. Your patient is in end of life, so even if we keep on giving dialysis, we are just buying time, and we'll still get to a point where we are not able to do the dialysis because the body cannot stand it. Yeah, so I would look at it that way. What's the prognosis? So, and then what is even the underlying autoimmune disease? What condition are we? Thank you.
And I think, Dr. Esther, obviously we don't have a lot of time with you today, but these kinds of conversations are not easy to have. And I think with experience, the palliative care teams that we work with closely, and now as we at AHN are starting to train up our own staff and hire palliative care nurses for our teams here in Kenya, we will become more proficient at having these kinds of conversations. The conversations will never be easy, regardless of how experienced you are in supportive and palliative care. I think this is something that is always going to be hard. These kinds of conversations are not easy. We have some tools to have these kinds of ethical conversations and shared decision making with our families and with the patients. But yeah, I think it's really important that we also consider how we communicate with our families. How do we have these team meetings or these family meetings, as Dr. Yuri was also mentioning? I think it's really important for us as providers to really think about that as well.
Yeah, I think
yeah.
One of the conversations we actually need to have is the advanced care planning conversation. Like for patients with chronic kidney disease, when is the best time to have these conversations? Who should initiate them? And I think just one point that I would like to put across is that the emphasis should not even be on signing a DNR or DNI, but rather just understanding what are the preferences of the patient, who is their decision maker in the event that they're not able to decide, so that, as Dr. Yuri has mentioned, sometimes relatives are making decisions that are not in the best interest of the patient. We want you to die quickly because there's some land we are hoping to inherit. So denying you dialysis, you die faster. So we need to have these conversations more regularly. Thank you.
Yeah, thanks so much. Dr. Esther is very good to work with. She's extremely busy, but she's always there to support her colleagues in Kenya for sure. So I'm sure she'll share contact information. But there's another interesting question on the chat from Samuel, who says there's a 12-year-old male patient who's developed chronic kidney failure due to nephrotic syndrome. Both parents have refused dialysis against the doctor's advice. How should we go about this scenario? It's a really interesting case. Any thoughts, Dr. Nafula?
So my starting point is that a 12-year-old is a minor. So in the laws of Kenya, the 12-year-old cannot decide for themselves, and the parents are the legal guardians, so they are legal decision makers. So in a scenario like this, we need to, first of all, look at whether the dialysis is a life-saving intervention, which from what I'm reading seems to be, because the doctors have recommended and advised it. So we would want to know maybe if there's any underlying problem. Why are the parents refusing dialysis? And sometimes you find parents refuse treatment because of maybe not understanding what to expect or having inadequate information about the disease and the plan. So they could also be refusing the dialysis because they feel it's maybe they do not understand what the benefits are going to be, how long their child is going to be on dialysis, and they could be also relating it. We know that in Kenya, a lot of diseases are blamed on witchcraft. Some people want to seek traditional healthcare advice before they come to hospital. So it is good first to determine the underlying problem of why they're refusing the treatment. So if it is something you can sort out, like giving them information and helping them to understand about the disease, that's an easy win. Sometimes we still explain and the parents refuse. In this case, this is a case that should be escalated to a hospital ethics committee if available, or a legal team, because legally a child should not be denied treatment. And once they come to hospital, our ultimate responsibility is to actually protect the child. So if the parents are making decisions that are not in the best interest of the child, the law allows us to override that decision, but we also have to do it through the legal channels. Don't just tell them, oh, we are going to give the treatment even if you don't want it. Use the correct channel so that if there's a complaint or a legal issue, it can still be sorted out. So you protect yourself and protect the institution. Thank you.
Yeah, thanks so much. I know we have a few other, there's a question from one of our nephrologists, Dr. Ngigi. Would you like to ask your question? Sorry, Dr.
I think he might
Maybe
have
he
dropped
can't.
out.
Oh, okay.
Yes, I think he was one of the panelists, but I think he dropped out.
Okay. There's a few more that have come in. There's a question from Jack. How about religious dilemmas? A patient has been attending the sessions well, but all of a sudden decides to pull out based on their faith, that they prayed for healing, yet you understand their prognosis is poor. How do we deal with this, kind of related to these ethical dilemmas that we see sometimes?
So this is common, not just for renal patients, but for many patients. We've seen a lot of patients decide to go for prayers instead of treatment, to the detriment of their health, actually. So again, when we are giving supportive or palliative care, spiritual care is part of the things that we do. So we do work with trained chaplains, not pastors who are coming to pray for patients, but trained chaplains who understand how to assess for spiritual need and how to support the patient. Now, the unfortunate bit about that situation of choosing prayers is that if your patient is sound of mind, they actually have a right to refuse treatment, and the patient's rights charter allows them to refuse treatment as long as they have information and they are sound of mind. So sometimes we try to reason with them, we try to look at the spiritual needs, and if the patient insists that they want to go for prayers, there's actually nothing much you can do, especially if it's an adult. If it's a child, then we have pathways to intervene. But for an adult, sadly, sometimes we actually watch them get worse and then they come back to us when there's nothing much we can do.
Yeah, it's complicated because obviously our main role as clinicians is to think about their physical health. But we know, of course, that supportive care kind of encapsulates all of that. So we do want to be supportive, yet also knowing kind of the ultimate situation that the patients often find themselves in. And it can be really difficult when we maybe don't agree with the patient's decision, or we're also finding we're having that ethical dilemma kind of internally ourselves. There's one more question that says, sympathetic dialysis is also a problem in Kenya. Relatives will sell everything they can do to do dialysis. how do you handle this? I haven't heard of the word specifically sympathetic dialysis before, but I think I understand the question. What do we do when patients and families are kind of willing to sell everything to do treatment when it may be that their prognosis is poor? I think that maybe is what she's getting at.
I also don't know what sympathetic dialysis is. I've not heard of it. I don't know if Yuri has heard of it.
Probably maybe I can reframe the question.
Yeah.
Yes.
This is one of those scenarios where, as much as the prognosis is poor, families just want to give up. I think I don't know whether it's an African thing that we want to do every possible thing to ensure that our kin, something is done. Even if
Yes.
sometimes you meet with the relatives and tell them prognosis is poor, there's no need to dialyze. They don't want to lose hope, so they just want to do any intervention available, even if it doesn't add any value. I think that's probably the question. How do you
Yes.
handle such family members? Yeah.
Those ones are also tricky because it's usually a case of denial. So we can see the problem right in front of us, but we do not want to accept that we are losing our relative. So we'll do everything and anything that is available. Now, that is a scenario that is hard to handle because sometimes we give information, but the relatives still go ahead and choose the interventions that you have talked to them and explain to them that it's futile. Now, when it comes to ethical issues, remember I mentioned that the decision that people make, we have to respect that decision, whether it makes sense to us or not. So our biggest role first is to offer the information and offer the support that we are able to give. Now, the decisions that are made, whether they will go with our recommendations or not, we need to be able to still support the family. So it's a scenario where we are really not able to do much because what usually happens is you will find they move to a different institution. So as we are saying, this patient does not need dialysis, but they'll go around until they find the doctor or the institution that will accept to offer that intervention. So we share the information and also give them psychological support to try and help them deal with the information, because most of it is usually we are not dealing well or we are not adjusting well to the information. We are not ready for the losses that are coming. So if we improve also the amount of psychological interventions that we are giving, some of these problems can lessen in our care.
Yeah, sometimes I find in these situations, if we can begin to understand where this fear is coming from, really understand the family to the best of our ability, it can help us counsel them. Yet, of course, these things take a lot of time and a lot of patience and a lot of energy. Dr. Mazar, I know that you're calling in from Tanzania. Do you have any comments on the conversations tonight? Dr. Mazar is our medical officer director in Tanzania.
Thank you, Erin. Thank you, Dr. Nafula, and the audience for all of these questions, and Dr. Nafula for your eloquent presentation. I think ethical dilemmas surround us, be it in the dialysis field or any kind of medical intervention field. And I mean, you went through it in a very nice step-by-step manner to try and make it a bit more clearer. However, in the day-to-day, practices that we have, we struggle to make, these decisions. At the end of the day, what is right for the patient, but the family has got a completely different idea, and you are always, kind of torn apart in between these two. What do you do? We know that if you do this, it's going to be not helpful, but the family wants it. And at the end of the day, you try your best to try and counsel the patient and do what they, at the end of the day, say that they have to do. I mean, patient autonomy is something that we have to respect, most of the time. And again, it also depends on where you practice. When I trained in South Africa, I trained in a state hospital where dialysis is offered free. However, in order to qualify for dialysis, you need to meet certain criteria. If you don't meet those criteria, then you are refused, renal replacement therapy, because the criteria is basically to be a transplantable candidate. If there is any reason you cannot be transplanted, you are not accepted onto the program. And I mean, if you zoom out a bit and you say, okay, that is very unethical practice, then if you are in that situation, you know that, okay, if you give dialysis to everybody, that particular funding that you have, you're going to lose out on. And patients who are able to actually benefit out of that program to go back and give to the community is going to be hampered. So you see, it's a very balancing situation depending on where you are, which country you are, and how you practice. So this is something that is probably going to stay with us for as long as we practice our medical career. And sometimes, we need to, as doctors, need to know when to stop, but we also need to make sure that we explain to our patients fairly explicitly, or the relatives fairly explicitly, as to what the outcome is. I believe that most of the time, if patients are adamant apart from denial, it's just that they do not have insight into the whole process of the disease and treatment. And it is something that we probably need to spend more time on with our patients and explain them, what the whole outcome is. And I believe that most of these may be able to be overcome. But yeah, thank you very much for this eloquent presentation. Thoroughly enjoyed it. Thank you.
Sorry, thank you, Dr. Nafula and Dr. Mazhar, Dr. Yuri. I see Dr. Lloyd is also with us. Dr. Lloyd, do you have any final thoughts?
And no, I think thank you very much, Dr. Nafula. It was a wonderful presentation, and sometimes quite often legal issues are there, but the ethical issues are always a very complex issue to deal. And now that we have a specific topic of kidney supportive care coming into nephrology, I think awareness of the entire domain is extremely important, and the ethical issues that are going to come into that and are already existing in that. And sometimes there is no right and wrong. And that approach of knowing and solving that is something very, very important, and especially in the nephrology community. And I think starting with the nurses and the nephrologists as well. So thank you very, very much for this wonderful presentation. And we hope to have it on YouTube, and this will be a landmark for us in our on our YouTube channel. Extremely grateful for the presentation. Thank you so much.
Well, thank you. Thank you, everyone, for joining us tonight. Dr. Nafula, I don't know if you realize there was about 70 people on the call, kind of from all over. Not everyone introduced themselves, but we had a great turnout tonight. And we're really glad that you're part of our team. Sometimes with these ethical dilemmas, it is talking to a trusted colleague and not necessarily feeling like you have to help a family make a decision by themselves. So people like Dr. Nafula, myself, Dr. Yuri, Dr. Mazhar, we're all here to support you in the work that you do every day. So please don't be a stranger. Keep in touch, and definitely if you need to reach out, please do. Have a good night, everyone.